Good afternoon. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership and Professor of Medicine at Harvard Medical School. And thank you for joining us for the 2021 Annual Leadership and Faculty Development Program Conference and Minority Health Policy Annual Meeting. The conference today, Equity and Social Justice Webinar, the role of primary care in health equity, will focus on the role of primary care, and included in this will be topics around men's health, access to care, career professions in primary care, and the insurance payer perspective. We'll discuss challenges facing primary care and opportunities and interventions to confront disparities, and therefore paving this way towards equitable health care. Other objectives of this 4-day annual leadership and faculty development conference and annual meeting include exposing participants to health disparities and health policies at all levels through the Commonwealth Fund Fellowship in Minority Health Policy at Harvard University and the Joseph L. Henry Oral Health Fellowship practicum presentations. We will also provide participants with career development training through 2 sessions. The first, Be Your Own Advocate for Career Advancement, Moving Beyond Imposter Syndrome and Self-Sabotage, and the second, Managing Stress During COVID-19 and Beyond. I'm pleased to say that there are over 250 registrants joining us today, including physicians, faculty, students, trainees, social workers, administrators across many different schools and community organizations. Today's webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, DICP. The mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identifies and trains leaders in academic medicine and health policy, and provides programs that address crucial pipeline issues. Today's webinar is offered through our DICP Equity and Social Justice Initiative. It is the 9th ESJ webinar in the current academic year. A little history: in the fall of 2016, a planning committee comprised of faculty, staff, and students representing members across our HMS community discussed the establishment of this Equity and Social Justice series to address health disparities, social determinants of health, leadership and health system, health policy, and other areas affecting vulnerable populations. And since 2016, an average of 10 to 12 programs have been provided annually in collaboration with our HMS affiliated institutions. ESJ events focus on 4 areas: 1, history and context; 2, culture and environment; 3, health disparities; and the 4th, leadership and skill development. This year, the ESJ lecture series tackles health issues that often impact disadvantaged and vulnerable populations. Our conversations and speakers address not just defining the disparity, but also discuss interventions at community, hospital, and policy levels. Now, a few housekeeping notes before we begin. Chat will not be available. Your microphones will be muted. You can use the Q&A to post questions to panelists. This webinar is closed caption and is being recorded, and that recording will be posted on the DICP website. It's now my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center and is the founder of Motivating Pathways, Inc. He is assistant professor of emergency medicine at Harvard Medical School and assistant dean of the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. And it's my pleasure to now turn the mic over to Dr. Landry.
Thank you, Dr. Reed, for that introduction and setting us up for our discussion on our Equity and Social Justice lecture, the role of primary care in health equity. We've been thinking about planning and pulling together this presentation for 2 years now. However, last year, because of the pandemic, we were unable to have this wonderful lecture and invite our guests to be here and speak with us. We're excited to be in this space virtually and to have this conversation. And we look forward to the conversation that happens in both from the panelists, as well as our keynote, as well as the conversation that comes as we engage you all in the question and answer session. As Dr. Reed mentioned, please take advantage of the Q&A option as you have questions for our speakers, both towards the end of the keynote presentation. Dr. Steinburg will take a few questions that I will choose from the questions that are submitted from the audience. And also as we do our Q&A with our panelists later on at the second half of our presentation, I'll review those questions and bring those to the forefront as part of our conversation. In the interest of time, I want to go ahead and introduce our keynote speaker, who is going to be Dr. Judith Steinburg. She is the Chief Medical Officer of the Department of Health and Human Services Office of Infectious Disease and HIV/AIDS Policy. As the CMO, Dr. Steinburg serves as Senior Subject Matter Expert, providing medical and scientific expert advice and counsel across the broad infectious disease portfolio of the office. Dr. Steinburg serves on the Advisory Committee for Immunization Practices for COVID-19 Vaccine Safety Technical Subgroup. And she has more than 25 years of experience as a primary care physician and in infectious disease, including caring for patients at community health centers and safety net institutions in Massachusetts. And I know Dr. Reed would be proud to say that she was a Commonwealth Fund Harvard University Fellow in Minority Health Policy in 2007 and 8, and received her master's degree in public health from Harvard University. And with that, I will turn it over to you, Dr. Steinburg, and thank you for joining us for this wonderful panel, your keynote discussion.
Well, thank you, and good afternoon, and maybe good morning to everyone. Thank you for that kind introduction, Alden. It's an honor and a pleasure to be here today to kick off the equity and social justice discussion. And it's such an important topic that thankfully and hopefully has risen to the top of the agenda for our nation. And I'll be sharing some of that with you today. So I'll start the discussion by examining the essential role of primary care in advancing health equity. Next slide. So in this presentation, I'll set the stage by grounding us in some definitions, reviewing some of the contributors to health, and then also highlighting some disparities, especially those that have come to the fore with the COVID-19 pandemic. Then we'll look at primary care and examples of advanced primary care models and the data that supports them. That'll lead us to a discussion of barriers and facilitators in implementing these advanced primary care models. And we'll bring it all together with what's needed going forward to advance primary care for health equity. Then I'll close with a look at the current landscape, which holds promise. Next slide. So what is health? According to the WHO, health is a state of complete physical, mental, and social well-being. That's well-being, not the absence of disease. And this is a definition that dates back to 1948 and rings true. So then what determines health? Here I'm giving a presentation on primary care, yet clinical care accounts for no more than 10 to 20% of the contribution to health. Social and economic factors and the physical environment account for about 50%, and health behaviors adds another 30%. And health behaviors are often related to social, environmental, and economic factors. So what are these contributing factors, these social and economic factors? These are the social determinants of health, the conditions under which we are born, grow, live, work, and age, according to Healthy People 2030, and this wonderful graphic that you see here. And I would say that added to these are racism, discrimination, violence, stigma, and the stress related to these. Next slide. So that brings us to health equity, attaining the highest level of health for all people. This is social justice in health. So what are health inequities? These are differences in opportunities that groups have to achieve optimal health. And the root causes are societal and structural inequities at these multiple levels that you see here. These are baked into our society, stemming from a legacy of historical and ongoing discrimination and bias, policies and programs that favor some groups over others. And health disparities are the metric for measuring health equity in our nation. Next slide. So health inequities have been known to us, but certainly the COVID-19 pandemic has exposed and highlighted health inequities in our nation. And this is not surprising. Health inequities are often and always exposed in the settings of emergencies, environmental disasters, infectious disease epidemics. Think Katrina. Think what just happened in Texas with extreme cold weather conditions. Think HIV. Under-resourced communities and populations always bear the brunt of these emergencies, and COVID-19 is the latest example. So in the current pandemic, Latinx populations and other minority populations accounted for a disproportionate share of COVID-19 cases, as you see here on the left. And African Americans and other minority populations had higher rates of death compared to whites. Next slide. And counties that have higher social vulnerability were at higher risk of becoming COVID-19 hotspots and had higher rates of rise of COVID-19 cases. So these are examples of health disparities in this pandemic, but health disparities exist across the board for life expectancy and maternal mortality, for conditions like obesity and diabetes, hypertension, HIV and sexually transmitted infections. The list goes on. These are disparities for racial and ethnic and other minority populations, and disparities by geography. And hopefully the COVID-19 pandemic will provide us a window of opportunity to address these inequities in our nation. Next slide. So now let's look at primary care. We all know primary care. It's where we go to get our annual physicals, although maybe not so much this past year. It's where we go when we don't feel well, we need a diagnosis and some treatment, and also for diagnosis and ongoing management of chronic conditions. It's the entry point to our healthcare system and a place to get referrals for specialists. And it's founded on an ongoing, trusting relationship between patient and provider. Next slide. So we know that primary care improves health outcomes. There's much data that show that better primary care is associated with more equitable distribution of health. And stronger primary care systems are generally associated with better population health outcomes, like you see here. Also, larger primary care workforce is associated with improved health outcomes. And I highly recommend this review by Shi and Scientifica. The world understood what primary care should be, and here you see it in the declaration, the Alma Ata Declaration in 1978. And again, it holds true. Next slide. So advancing from the basics and now understanding better the contributing factors to health. What if primary care looked like this? Focusing on the entire person, the physical and behavioral conditions that the person might have, as well as their social, cultural, and economic context. This requires a multidisciplinary team. Making it easy to access care through different avenues, not only in-person visits, but also through telehealth, remote patient monitoring, and in the HIV sphere, rapid access clinics for HIV pre-exposure prophylaxis. And then expanding preventive services. This is what I'm currently focusing on in implementing the Ending the HIV Epidemic initiative. And integrating services for one-stop shopping so that we have better access to care and better coordination of care across a team that's integrated across disciplines. And this allows for warm handoffs by providers of different disciplines at the point of the visit. Imagine coming into care and being able to have a conversation in a comfortable, welcoming environment with a trusted partner, your provider, talking about substance use and being able to get access to treatment on the spot. And then being responsive to the needs of individuals and communities that are served. This means attending to patients' social determinants of health, and also providing advanced primary care that's informed by and engaged with the community served so that we can improve the health of the community. Next slide. So this type of advanced primary care is being implemented across the nation. So now I'd like to take a look at a few of these models. Next slide. And what better place to start than the health center program? I love this photo of LBJ signing the health center program into law. Born of the War on Poverty in 1965, the health center program was built to improve the health of underserved and vulnerable populations, reduce disparities, and advance health equity. It's our country's safety net for primary care. But I would argue it's also an exemplary model of what primary care could be. Next slide. So here are some key elements of the health center program that are built into the funding mechanism and the requirements of grantees. They are to serve high-need areas and provide comprehensive primary care and enabling services, such as education, outreach, and transportation services. They are to be collaborative with community providers to maximize resources. They are truly patient and community directed. They are governed by a patient majority board. No one is turned away. Services are available no matter one's ability to pay. And grantees are held accountable for complying with program requirements and for reporting on data. And that data, some of that data you'll be seeing shortly. Next slide. So now, many decades later, there are 1,400 health centers that operate over 13,000 service delivery sites across the nation. That's all the green dots that you see here on the map. In 2019, nearly 30 million people received their care at a health center. And through forward thinking and intentional investments, the health center program integrates primary medical care with oral and mental health services, and more recently with substance use treatment services. And it's expanding its definition of enabling services to include addressing social determinants of health. Next slide. So the health center program is achieving its mission to provide care to underserved populations and to advance access to care. So here's 2019 data. The program cared for 1 in 3 people living in poverty, 1 in 5 uninsured individuals, 1 in 5 rural residents, and 1 in 8 children. 91% of those served by health centers in 2019 had incomes at or below 200% of the poverty level. And 63% were racial or ethnic minorities. Next slide. So what about quality of care? Again, looking at 2019 data, on many measures of quality, the health center program either equaled or outperformed national averages. And they also outperformed many measures on Healthy People 2020, actually the targets of Healthy People 2020. Next slide. So here's evidence of the impact of integration on behavioral health and primary care. Over the years, the Bureau of Primary Health Care provided additional funding to health centers to integrate mental health and, more recently, substance use treatment services. And this actually was in response to the opioid and substance use disorder epidemic. Take a look at the growth in medication-assisted treatment at health centers as a result of this funding. Next slide. And for the COVID-19 response, again, health centers were called upon to provide testing and treatment initially, and in particular to reach and engage disproportionately impacted populations. And now with the American Rescue Plan Act, that the additional ask is to provide COVID-19 vaccination to disproportionately impacted populations. And this funding will more than double the budget for the health center program, more than double. Next slide. So here's a real life example of a health center in Tennessee that has an exemplary model of behavioral health integration. It's Cherokee Health Systems. Its foundation is an integrated team that includes a behaviorist, which is usually a clinical psychologist, a psychiatrist, a community health coordinator and the primary care provider, as well as a clinical pharmacist. And this team works together to co-manage patients, and they provide warm handoffs at the time of a visit so that patients have immediate access for behavioral health care right at the time of a visit. It also this model ensures coordination of care because there's co-management by an integrated primary care team. And there are many health centers that have implemented this type of model. Next slide. Nope, there you go. So recognizing the importance of social determinants of health as contributing factors to health, in 2019, 70% of health centers were routinely asking their patients about their social determinants of health and providing services to address these factors with them. And this has been sparked in part by a collaborative effort from the partners that you see here called PREPARE, which is an acronym. And it's actually an entire protocol that includes a standardized risk assessment tool and a toolkit for implementing this risk assessment and addressing patients' social needs in practice. And health centers partner with community-based organizations, public health departments, and others to help address their patients' needs. Next slide. So here's another model of advanced primary care, the patient-centered medical home. It was originally conceived as a model of care for children with special health care needs. And then in 2007, with the coming together of primary care professional societies to issue the joint principles on the patient-centered medical home, it became a standardized primary care, advanced primary care model. And so this is a graphic that we developed in UMass when we were implementing the Massachusetts statewide multi-payer patient-centered medical home initiative. That was in 2011 through 2014. And as you can see here, the patient is at the center and care is delivered by a multidisciplinary team with the team members listed here. And the patient-centered medical home, excuse me, provides these services and functions for the patients and for the community. So, nope, can you go back? Accrediting bodies like the National Committee on Quality Assurance and the Joint Commission have developed recognition programs for practices that have, excuse me, that have implemented the patient-centered medical home. And then oftentimes when they are recognized as patient-centered medical homes, states and payers, public and private payers, will pay additional funds for these more highly recognized practices. So what's the scale of this around the country? Well, approximately 13,000 primary care practices with more than 67,000 clinicians across the nation have been recognized as patient-centered medical homes by NCQA. And the Bureau of Primary Health Care is supporting health centers to become recognized as patient-centered medical homes. As of 2019, 78% of health centers have been so recognized. Next slide. So let's take a look at payment models for advanced primary care. And you may ask, why is payment so important? We're talking about health equity. But you get what you pay for. And the traditional model of primary care is fee-for-service. The primary care provider delivers an office visit or provides a procedure, bills for that, and the payer pays for that service. This payment model, this type of payment model, as you can imagine, incentivizes for more visits and does nothing to incentivize for comprehensive coordinated care. And this traditional model does not pay for addressing social determinants of health. There's no billing code for that. So payment models for advanced primary care shift away from fee-for-service and incrementally aim to replace fee-for-service with a comprehensive primary care payment that would be paid monthly based on the population, the numbers of patients served, and the complexity of the population served in that practice. And usually a performance-based payment is added to this to incentivize for quality and for reductions in cost and utilization. Incentives need to be aligned with the model of care we desire. In the early days of implementing the patient-centered medical home, fee-for-service was still and is still the main driver of a practice's revenue. It was very difficult for practices to change their model of care when they were getting their revenue from having increased numbers of visits. And we need to change the model of care in order to help improve health equity. So another factor is risk adjustment. This is about equitably allocating our healthcare dollars to serve the needs of patients. Risk adjustment models assess and predict the level of utilization and the cost incurred by patients based on age, gender, and diagnoses. And then payment can be adjusted based on this level of complexity of the patients served, the population served. And innovation in risk adjustment is to include indicators of social determinants of health, like housing instability, employment, and education. In Massachusetts, I convened a team of risk adjustment experts from UMass Medical School to update and revise the Massachusetts Medicaid risk adjustment model to include these indicators. And now it's being used as the risk adjustment model in Mass Health's accountable care organizations. And although it's not scaled up across the nation, many states are interested in incorporating this type of model. And there are discussions being had with CMS to use this type model. Next slide. So many states have been embarking on primary care transformation. And here I'll highlight just one example because of time constraints. But you should know that besides Rhode Island, other states to look at are Colorado and Oregon, Michigan and Minnesota, and Washington, for example. So Rhode Island's Care Transformation Collaborative is a multi-payer initiative to expand the patient-centered medical home across Rhode Island. And multi-payer, that is public and private payers, that's important because new payment models and therefore the incentives need to be aligned across multiple payers. Most practices receive their revenue from multiple payers. So again, the incentives need to be aligned if they're going to change their model of care. So the Rhode Island model also includes community health teams that are expanders of primary care. Practices refer their high-risk patients to a community health team that includes community health workers, behavioral health clinicians, and peer recovery coaches. And they provide an assessment and intensive coordination, care coordination services. So patient-centered medical homes don't have to do it all. They really can't. Integration of behavioral health and primary care has also been added to the model. And here you see the dramatic rises in the percent of patients who have been screened for behavioral health conditions and substance use as a result of this integration of behavioral health. And there's evidence that the patient-centered medical homes in Rhode Island, in particular those that integrate behavioral health, are saving dollars. Next slide. To give you a better sense of the interest in advancing primary care across states, I really wanted to highlight this initiative, Advancing Primary Care Innovation in Medicaid Managed Care. It's being provided by the Centers for Healthcare Strategies and supported by the Commonwealth Fund. And here, 10 states are supported in advancing primary care to include these components that you see here, using the levers of Medicaid managed care. Next slide. So what about at the federal level? Here, the main player is the Center for Medicare and Medicaid Innovation, or CMMI. And CMMI currently has 2 advanced primary care models. Comprehensive Primary Care Plus is in its 4th and final year and has been expanding advanced primary care across 3,000 primary care practices. It's a multi-payer initiative. There's a very clearly defined clearly defined care delivery model, and practices need to reach milestones in implementing these components of the model. It incrementally advances the payment model, especially for track 2. And then primary care first, the more recent model. This really is taking it to the next level because they're enrolling practices that have already achieved advanced primary care models. It too is multi-payer. It further advances the payment model to reduce fee-for-service and have more of a preponderance of that comprehensive primary care payment. And practices that see more complex patients are incentivized by receiving more dollars. And they are required to provide supports for social determinants of health and integrate behavioral health and primary care. Next slide. So what's the data for all this? Most, if not all, evaluations of efforts and initiatives to transform primary care evaluate impact on 3 domains. First, quality, cost and utilization, and patient experience. And that's an important point. For the most part, payers' intentions in participating in these initiatives have been to lower total cost of care and preserve or improve quality. So although many of the models, when evaluated singularly, have shown reductions in acute hospitalizations and inpatient hospital and emergency department visits and total cost of care, as well as some improvements in quality of care. In an analysis of 45 peer-reviewed studies that was conducted by the Primary Care Collaborative in 2016 to 2017, the results were rather mixed. There was a more positive trend for reductions in total cost for practices that had mature patient-centered medical homes and for practices that were caring for more complex patients. And the year 3 evaluation of Comprehensive Primary Care Plus also showed some small improvements in the measures of impact and increased Medicare expenditures. So why such results? Transforming primary care practices to these advanced models is hard and it takes time. And often these evaluations are done at a point in time where practices haven't fully advanced and it's just too early to see impact. As you saw, more mature practices seem to have impact. Also, primary care can't do it all. There are factors beyond the control of primary care, including the social determinants of health. And many of the models really did not include the addressing of social determinants of health for patients. And then there's the lack of alignment of incentives across the healthcare system. Specialists and hospitals are being incentivized for high volume, high cost care. And these studies measure total cost of care. It would be very hard for primary care practices to have significant impact on total cost of care when the big spenders are continuing to be incentivized to spend more. Next slide. So what about health equity? What's the impact of these advanced primary care models on equity and the measure of equity disparities? Our colleague Nwando and her colleagues conducted a systematic review of the evidence of the patient-centered medical home's impact on these factors and actually found only 4 studies that fit their criteria for review. There was some impact on disparities across these 4 studies, but I think the main message was that more research needs to be done to evaluate patient-centered medical homes' impact on health equity. And I think it also implies that the patient-centered medical home model didn't expressly aim to address health disparities because you evaluate impact based on your aim. In another study by DeMarcus et al. That included Nwando as a senior author, they conducted structured interviews with stakeholders to get their viewpoints about the patient-centered medical home and health equity. And the general sentiment was that the patient-centered medical home and its policies and incentives that go with it really need to go beyond basic medical services to address the social needs of patients and the communities they serve. Next slide. So transforming primary care into these advanced primary care models is hard. Let's take a look at the barriers and also the facilitators. And first, the barriers. Well, at the top of the list is lack of access to insurance coverage and also underinsurance. Plan designs that include high deductibles actually discourage primary care utilization. And there's also lack of access due to geography and distance, transportation barriers, and lack of access due to social issues, bias, both implicit and explicit, medical mistrust, and stigma. Working in the HIV sphere, I have to say that these are very significant issues. Also, barriers related to the workforce. At the simplest level, the numbers. The numbers of primary care physicians are dwindling as our system incentivizes young physicians to choose higher paying specialty care practices and specialty care that often go along with a better work-life balance. And then workforce skills, cultural humility, and diversity. Lack of educational opportunities and role models, bias that's baked into admissions policies, and the lack of a diverse faculty actually all hold us back from a diverse workforce. And another barrier around workforce is our current approach to health professions education, which is siloed by discipline and set at hospitals and large institutions. But having a multidisciplinary team that works together, speaks the same language, and is responsive to the needs of the community really requires interprofessional education that's based in community settings. And I've seen this as a medical director in trying to hire a behavioralist to serve on our integrated team, and just couldn't find a behavioralist that was trained to work in a primary care team and felt comfortable doing that. The lack of investment in primary care is also a barrier. The United States spends on average 5 to 8% of its healthcare dollars on primary care, whereas our peer countries, other developed countries, spend about 14% of their healthcare dollars on primary care. And then structural factors within our society and discriminatory policies keep people from attaining the highest levels of health. And these are significant barriers. But we know the facilitators. First, improving health insurance coverage, but also catalysts such as federal and state agencies and multi-stakeholder collaboratives. These entities have been working on advancing our entire healthcare system, not only primary care, through innovations like accountable care organizations and accountable communities for health. And advanced primary care needs to fit into these innovative models. And this, to me, highlights the need for leadership at these levels, but also leadership in the practices. Leaders need to set the vision for transforming primary care and then provide the resources for change to actually happen. And we need leadership at academic institutions, professional societies, and in the communities. These are all facilitators. Partnerships with communities, including community leaders and community-based organizations, are also facilitators, as well as partnerships with hospitals and specialty care and public health departments. And then, given our complex healthcare system and social service system, data has shown the value of community health workers and peer navigators. This part of our workforce is of the community. They connect with people where they are, and also culturally and linguistically. They provide support to people to get the services that they need and the medications that they need, and to help keep them in care. I can't emphasize enough the important role of this component of our healthcare workforce. And then technology and data are facilitators. As we've seen with COVID-19, telehealth provides access to care and meets people where they are. And health IT is important for understanding our patient population and to monitor population health. And practices use this information to identify those individuals amongst their patient panel who need more intensive services. This is risk stratification. Data sharing is critical. Primary care doesn't have all the data. Data from multiple sources provides the entire story, and you need that entire story in order to provide comprehensive coordinated care. So we need data from payer claims data, public health surveillance data, data from community-based organizations, and community-level data. And also data sharing needs to be bidirectional. And last, but definitely not least, if we want primary care that's patient and family-centered and responsive to the needs of the community, then patients and communities must be partners in the solution. Next slide. So now let's take a look at the state of primary care and the need to increase primary care spend. Primary care practices were really hit hard by the COVID-19 pandemic, and many are closed or in financial distress. And interestingly, the COVID-19 pandemic response did not really include primary care, except for health centers. And this may be a statement of the extent to which primary care is valued in our healthcare system. And in its 2020 review of primary care spend, the Primary Care Collaborative found that actually primary care spending decreased from 2017 to 2019, and utilization was flat or declining. But there is hope. 10 states are now measuring primary care with the aim of increasing spending. And as you all know, if you don't measure it, you don't know it, and then you don't do anything about it. And several states have set primary care spending targets at the 10 to 12% level. Next slide. So let's bring this together now. And now that we have a better understanding of the facilitators and barriers, and get to what do we need to do to really make primary care a catalyst for health equity. Well, first, I would say we need to update the definition of advanced primary care to more fully encompass its important role in health equity and in reducing disparities. Being clear on what we're aiming for drives the model, the funding, and the accountability. Then we need to incentivize primary care and the entire healthcare system for health equity and monitor impact. This gets at having aligned incentives across the healthcare system and payment models that equitably allocate funds across based on the full complexity of the population served, not only on diagnoses, but also on social risk factors. And this also means that we need to be collecting information on race and ethnicity, demographic data, race and ethnicity, gender identity and sexual orientation, data on social determinants of health, so that we have disaggregated data to evaluate for health disparities. And we need to assess community level data, community level health outcomes. Now, primary care is one component, albeit a foundational component of our health system, but as I showed you, primary care cannot do it alone. So we need to align and synergize our work with these other innovative transformation models. I showed you the importance of increasing primary care spend. Data show that achieving better outcomes, we need to spend more on primary care. And we have much work to do in aligning and changing our policies and practices towards health equity, not only at the payer and practice levels, but at federal and state agencies, and not only for health-related agencies. We need to take a health in all approach, addressing policies on housing, employment, labor, transportation, food assistance, for example. And health professions education needs to change. A great summary of the change that's needed in health professions education was recently published by Alden Landry. Next slide. So, can we accomplish all this? Well, I would say that the current landscape holds promise, and here's what I see. More states are expanding Medicaid, and Medicaid coverage is expanding. The American Rescue Plan Act extended Medicaid coverage for postpartum women to at least 1 year. And the American Rescue Plan also significantly expanded the ACA and access to marketplace plans, and has the potential to cut child poverty in half. There's a concerted focus on health equity and environmental justice across sectors, federal and state government, professional societies, and academia. At the federal level, examples are the convening of the COVID-19 Health Equity Task Force and the Environmental Justice Task Force. Also, efforts to modernize data collection and focus on the need to include data stratified by populations. And agencies have health equity agendas, strategic plans, and task forces. States are escalating the transformation efforts for the healthcare system to include a focus on health equity. And as you saw, many states are increasing their primary care spend. And then the COVID-19 pandemic, which has been a heartbreaking and challenging time for our people, our communities, and our nation. But there have been some lessons learned from the COVID-19 pandemic, and with challenge comes innovation. So for example, HHS and CMS are working to maintain many of the flexibilities that were put into place to expand telehealth during the public health emergency and provide better access to care for patients. And the pandemic also underscored the importance of listening to and working with communities to reduce disparities, like working with communities and community leaders to enhance vaccine confidence for COVID-19 vaccination. And I expect this will be a long-lasting approach, certainly for our office in the Office of Infectious Disease Policy, where we generally work on increasing vaccine confidence and vaccination rates. And then just today, actually as I speak, the National Academies of Science and Engineering are releasing their 2021 report on implementing high-quality primary care. And this comes with not only an extensive review of the literature and recommendations, but importantly, an implementation plan so that we have action steps clearly identified to make this happen. Health equity is a major focus of this effort, and it's baked into the definition of high-quality primary care. And last, the work that I'm currently doing in the Office of Infectious Disease and HIV/AIDS Policy. We released 4 national strategic plans over the last few months on HIV, viral hepatitis, sexually transmitted infections, and vaccines. And they're all aligned, and they call for better integration of infectious disease screening, prevention, and treatment in primary care, as well as in other settings. Next slide. So we've come to the end of the presentation, and I'll summarize with some key takeaways. Stronger primary care improves health outcomes and health equity. I've showed you how the Health Center program succeeds in providing healthcare for underserved and vulnerable populations and is advancing its model of care. Reducing disparities and improving health equity has not really been a main focus of advanced primary care model and transformation efforts, but that's changing. Primary care transformation is hard, and primary care can't do it alone. And patients and communities must be at the center and partners in the solutions. Lastly, the current landscape holds promise to advance primary care and health equity. Next slide. So I reached out to friends and colleagues to inform this presentation, and I'd like to acknowledge them. Here's the list. I'd also like to acknowledge and thank our Office of Infectious Disease and HIV/AIDS Policy and the Office of Assistant Secretary for Health and the wonderful team that I work with. Next slide. Thank you all. Here's my contact information and the links to the websites for our offices. And now it's time for questions and discussion. Thank you.
Thank you, Dr. Steinburg, for that wonderful presentation. That you hit on so many great topics, and I think it's great that you're going to take a couple questions from the audience, and then we'll also maybe piggyback some of these questions that will go on to our panelists as we continue the second half of the discussion. So one question that I had for you was around the role of IT, and how can we can you comment on the role of how we can better use IT in improving primary care, especially as we think about disadvantaged populations? And as we think about using IT, how do we get more data in that space, whether it's collecting social determinants of health data, or even just collecting the basics around race, ethnicity, language, or sexual orientation and gender identity data?
Yeah. So thank you for that question. And yeah, IT is a facilitator. I know that for those who practice and are using electronic medical records, you may question that, but it does hold a lot of potential, and enhanced electronic medical records that really help support patient access and comprehensive coordinated care really could be in our future. But in terms of collecting the data, it's very important to collect it, but it's not necessarily so easy. The Health Center program actually embarked on asking health centers to collect gender identity and sexual orientation and gender identity data of their patients, as well as you see they're beginning to collect data on social determinants of health. And it takes some skill and cultural humility to ask those kind of questions, and to make patients feel comfortable and secure in why those questions might be asked. So there's some learnings to be done about that, but I can't emphasize enough the importance of collecting that kind of information so that we can do a better job in serving the needs of our patients and also to better monitor our impact.
Thank you. And there was a question from the audience, and it reads, many diverse communities, particularly communities of color, have a tenuous or tense relationship with healthcare providers.
Right.
How can we rebuild these bridges in order to accomplish systemic positive change in primary care service delivery and access? Yeah.
So there is a lot of medical mistrust from the legacy of historical discriminatory programs and policies. And we do need to rebuild it. And for primary care, I think that starts with that building of that ongoing trusting relationship. So for example, we know that for something very relevant for this time in terms of enhancing vaccine confidence for the COVID-19 vaccine, we know that the comments and the guidance of primary care providers is really helpful for patients to understand and for their concerns about vaccines to be addressed, and really has impact on enhancing vaccine confidence. So enhancing that ongoing trusting relationship, I think, will help move us forward and advance from that medical mistrust. But there are a lot of factors that stand in the way of that. And some of that is just the way our healthcare system and insurance policies are set up, with people not having that ongoing relationship with a particular provider. And also that fee-for-service model that incentivizes lots of visits every 10, 15 minutes, hard to have a relationship that way. So we have some systemic factors that we need to address to improve that relationship and dispel a lot of that medical mistrust.
Wonderful. And I see that there's a couple other questions that are coming into the Q&A. We're going to try and hold off on those because I want to make sure we give ample time for our panelists. But Dr. Steinburg has agreed to jump back in towards the end of our presentation and field some additional questions. So I just want to say again, thank you, Dr. Steinburg, for joining us, for your wonderful presentation and really helping us set the tone for the rest of our conversation as we talk about advancing health equity and the role of primary care.
Thank you.
So we're going to transition now to our panel discussion. We have three amazing individuals who are joining us, who are going to help share their insights and their experiences in the work that they do as primary care providers, and the leadership work that they do in various spaces that they operate. So I'll briefly introduce our panelists, and then we're going to jump right into additional questions for them. So the first person I'd like to introduce is Dr. Sarah Fazio. She is a professor of medicine at Beth Israel Deaconess Medical Center, and she is the Associate Director of Innovation in Medical Education for the Harvard Center for Primary Care. Next is Dr. Ross Jones, who is a clinical assistant professor at the University of Florida. He's the medical director of community health at the University of Florida Health, Jacksonville, Florida. And he is also an alum of the Commonwealth Fund Fellowship in Minority Health Policy. And last, but certainly not least, is Dr. Maria Portela Martinez. She is a Chief of Family Medicine at the Bridge to Care Medical Director for the George Washington University School of Medicine and Health Sciences. And she is also an alum of the Commonwealth Fund Fellowship in Minority Health Policy here at Harvard University. And so I actually want to turn to you first, Dr. Fazio, and really building upon part of the conversation that Dr. Steinburg presented to us, and having a conversation around careers in primary care, talking about the profession itself. So can you give us a little bit more information about what is the current status of the primary care workforce? And can you talk a little bit about what we need to do to ensure that students, our medical students, see primary care as a sustainable career for them in the long run?
Absolutely. Thanks so much, Dr. Landry. So, as Dr. Steinberg said, the United States has a disproportionately high number of specialists relative to primary care providers, and the density of primary care physicians, unfortunately, is continuing to decrease. According to the AAMC, by roughly the year 2033, there'll be a shortfall anywhere between 21,000 to 55,000 primary care physicians predicted for the United States, but that's actually a conservative estimate because it really doesn't take into account the maldistribution of primary care in our country. In a paper from the Annals that actually was published from a team at the HMS Center for Primary Care, there was a study that demonstrated that alleviating primary care shortages in the United States would actually increase life expectancy. But the data would suggest that we need to train an additional 100,000 PCPs to practice in underserved areas for this to be actualized. We also know that the physician workforce does not represent, as we've heard, the demographic characteristics in the US population at all. Racial and ethnic minority physicians are more likely to practice primary care and serve in medically underserved and rural areas than non-minority doctors. But despite this, Black, Hispanic, and Native American physicians make up only 13.4% of the primary care physician cohort, compared to over 30% of the United States population. So to get students to see primary care as a sustainable career, which I spend a lot of my time doing, I would say that there are really 5 things that are critically important. The first is an increased emphasis on high quality primary care rotations and experiences at the medical school level, including more community-based practices, not just academic practices. Most of our students are currently imprinted to choose inpatient specialties based on what they experience, so it's not surprising. The second is for students to see it as a sustainable career. We really need to provide the tools to meet our patients' needs. And it's so much of what Dr. Steinberg discussed. Students should be exposed to patient-centered medical homes with embedded social workers for mental health and community health workers for outreach. We need to look at many models, one of which is City Block Health, which is actually a startup that began in New York, that's working with Medicaid patients to avoid emergency room visits and hospitalizations by addressing social determinants of health. And they do this by providing primary care with the resources to care for patients at home and in the community. The third is reimbursement and loan forgiveness for our students. These programs need to be enhanced so that students are encouraged to pursue primary care specialties over procedural specialties that have more than enough representation. The fourth, which is incredibly important, I think at so many levels, is deregulation and an improved work environment if you want students to be choosing this as a career, so that the job is about patient care and not about administrative and documentation tasks, which can take up to 39% of a primary care physician's time, according to one study. We need to allow our clinicians the opportunity to innovate and improve care and based in patient needs, enhance the team-based care to allow the physician providers to predominantly focus on diagnostic challenges and complex medical issues, which we're trained to do, and really change change our practices to allow us to fulfill the needs of our patients, which we really can't do in the confines of the way that primary care medicine is currently practiced. And then the fifth, I would say, which is sort of obvious, is compensation. Certainly for our graduates with their loan and other debts going forward, we need to pay more for the work and ideally change from a fee for service to a prospective payment system, but one that's high enough to enable the kind of work that actually needs to be done.
Great. And my next question for you, I think ties in points 4 and 5 that you were just talking about, both the innovation and the compensation. As we think about COVID-19 and how it's impacted access to primary care, and with the decrease in use of the way Dr. Steinburg commented on, but one of the things that we saw was people were really embracing telehealth, which is innovation, which is meeting patients where they're need. But as we're thinking about how telehealth is going to be a part of healthcare going forward, what does that mean as far as compensation? And so I guess my big question to you is, how do you envision telehealth being a part of the future of primary care? And what will be the impact on the primary care workforce?
Yeah, no, it's a great question. Thanks for asking that, Dr. Landry. So as we've heard, primary care volume declined by about 25 to 50% during the first 4 months of the pandemic. And then it rebounded by about August to level off at a decline of about 10% compared to years past. The share of visits delivered by phone or video increased dramatically, amounting to about 35% of the primary care visits during the same period of time. But despite the increased use of telemedicine, particularly early on, there was a decrease in overall primary care utilization, particularly dramatic in community health centers that cared for underserved populations. At the onset of the pandemic, practices obviously switched to telemedicine quite quickly, which was wonderful, but patients with known barriers to digital access, so the older patients, low-income patients, those with limited English proficiency, and minorities were less likely to utilize primary care, and there are obvious long-term effects of that. Telehealth, as you pointed out, Alden, has subsequently become a really critical part of primary care, and I think a very positive thing as the pandemic has gone on, even though clinical practices are starting to begin to return to inpatient visits, depending on where you are. We're maintaining a larger presence of telemedicine than we did before. In many ways, it's a good thing. It can provide critical access to patients who can't make it in person, particularly for those in whom travel is costly or would require them to miss work. And for visits that are predominantly counseling related, or even the annual well visits, we've learned that we can easily substitute telemedicine for face-to-face visits, and probably in a better way in some capacities. But they need to be paid at the same level as in-person visits for it to be sustainable as well as valuable. And I think the main thing is that it will be crucial for health systems to standardize work for remote ambulatory care that explicitly ensures equitable access to telemedicine, which really is not the case right now. Under-resourced health systems have less device, software, and broadband access, as well as lower payment rates per care episode, which basically results in lower telemedicine payments for practices that disproportionately care for patients with lower digital access and in underserved areas. So we've got a lot of work to do in that regard.
Thank you. And I think it's really important for us to think about, it's a two-sided aspect. It's one, when it comes to telehealth, not only do the patients have the ability to engage in telehealth by having cameras or smartphones or tablets where they can have a camera that will allow them to see their provider, but then also making sure that the physicians themselves have access to the infrastructure and the tools and the scheduling and all the other IT resources that are needed in order for them to be able to engage the patient. So both the patient and the physician both need to be equipped. And we need to make sure that as we are engaging in this new technology, that we're actually supporting everyone involved. And I just have one final question for you, and it stems to some of the comments you made earlier around workforce diversity. Can you just talk a little bit more about the need for a continued diverse workforce in primary care? And as there's a question that's coming from the audience about not just diversity in as far as race and ethnicity, but also thinking about diversity as far as geographic locations and so forth. So however you like to tackle that question.
Yeah, no, thank you. It's such an important question. Inequities in primary care access are really a product of longstanding structural racism, from racial segregation in both rural as well as urban areas of the United States, associated with worse healthcare access and higher financial, insurance, and geospatial barriers to primary care. So many studies have suggested that the health care of underrepresented minorities is improved when providers of similar ethnic and racial backgrounds provide the care to them. And we know that diversifying the medical workforce improves patient-physician communication and improves the trust we've been talking about that is so critical in the relationship, as well as recommendations given and whether patients actually listen to those recommendations, and increases adherence to treatment plans. So it's in many ways so critically important. In addition, as you've suggested, Dr. Landry, increasing physician representation from URIM populations is very likely to help reduce the persistent geographic maldistribution of the overall physician workforce, which is really one of our greatest problems. We need physicians who can understand the lived experience of our patients and also who speak the languages of our patients. Pipeline programs are obviously critical for a more diverse workforce, along with an increased focus on the achievement of diversity in the selection and recruitment process for medical school. To that end, I think it's critically important to increase the funding of federal programs that support the recruitment of minority students, partner with historically Black colleges and universities, and provide students with the mentorship, tutoring, and resources that they need to apply for medical school and get excited about this as a career choice. I would be remiss if I didn't sort of mention on the GME side, which is one step ahead, but also pretty important, passing the Resident Physician Shortage Reduction Act would increase the number of Medicare-supported GME slots with priority for rural areas and programs serving patients in health professional shortage areas. It would also direct the Government Accountability Office to commission a report increasing workforce diversity, which I think is something that we really need.
I want to say thank you for doing two things in that. One is touching on something that I'm really passionate about, which is addressing the pipeline to careers in medicine, and then also taking it to a policy and legislative standpoint by talking about some of the changes that can happen on a policy level to encourage physicians to go into primary care. So thank you for your answers for the questions, Dr. Fazio. I want to go next to Dr. Portela Martinez and have a different set of conversations, but still focusing on access to care. Dr. Steinburg referenced some legislative acts in the past. She also mentioned the Affordable Care Act. Can you talk specifically about how the Affordable Care Act has led to an increase in access to care and maybe some other impacts that were a result of this huge legislative policy almost 10 years ago?
Sure thing, and thank you so much for having me. I think Dr. Steinberg, as mentioned, highlighted some of these things, but essentially the Affordable Care Act, one of the major significant gains was a significant reduction in the amount of uninsured Americans. That although it has been at an all-time low and a few years back, and it has started to increase in terms of the amount of people that are uninsured after a few legislation changes in the past administration, there's still significant gains. Most of the significant gains were achieved through Medicaid expansion. So a lot of states, the way that Medicaid essentially worked was a little bit state dependent, but up to 100% of the federal poverty level, if a patient qualified under that criteria, they would be eligible for Medicaid. And the Affordable Care Act expanded that, the federal poverty level guideline, and included millions of people to be able to be under coverage. It also expanded the amount of services that Medicaid would offer, and it also created the ACA marketplace, which many of us know or have heard of, that have been very controversial, but essentially that allowed premium subsidies to be offered to patients that would enroll in commercial insurance plans and made healthcare more affordable in most circumstances. So through the Medicaid expansion, which states had an option of opting in or opting out, initially about half of the states opted in, maybe a little bit less, and over time, more states have opted in, with the majority of them now being part of that Medicaid expansion. The Medicaid expansion looks differently, can look differently from state to state, and states were given some flexibility in how to apply the Medicaid expansion funds. But overall, those were the biggest gains. The other main gain was from, in terms of insurance coverage, from allowing dependents up to the age of 26 to stay on their parents' insurance plan. And that was also a significant gain. And then, as Dr. Steinberg mentioned, there were several specific provisions in terms of primary care, investments in primary care workforce, investments on federally qualified health centers, over $11 billion, where a large population receives primary care and sometimes even specialty services. And then there were other investments that she mentioned as well, such as the grants and innovative healthcare delivery system innovation programs that were created, from the creation of CMMI or the development of it, and just many incentives for graduate medical education programs to really train the future healthcare providers in innovative ways and in new healthcare delivery systems.
And what I get from what you're presenting is that a lot of people don't realize how expansive the original Affordable Care Act was when it was presented. We really focused in on the insurance component of that, but we didn't think about some of the other amazing components that were included in this, including the ability of individuals to stay on parents' insurance for longer, some of the space working around the space of graduate medical education. And we know that the program went pretty far, and there were a lot of gains. But I guess maybe the question to you is, as we talk about these gains from the program, and this may be more of a rhetorical question, do those gains really mean access, guaranteed access to high quality services?
Yeah, they don't. One of the things that essentially the gains, what they mean, literally speaking, is that you are, somebody's obtaining health insurance coverage, but that can be incredibly variable depending on the state and depending on the provider workforce, as Dr. Facio mentioned, and depending on many things, like also the knowledge or the understanding of the healthcare system, of patients, etc. And one of the articles that brings that reminds me of, that Dr. Somers, one of my mentors from the fellowship year, introduced me to, is translating insurance coverage into voltage gaps and into high quality healthcare services. So there's this article by Dr. Power that essentially outlines all of the vulnerable areas that our US healthcare system has, where people, even if they have access to health insurance, can fall through the cracks and not receive any access to care, or not high quality access to care. And those vulnerable areas include, one, receiving the actual health insurance, which is what one of the main things that the Affordable Care Act tackled. Number two is actually having the primary care workforce available to be able to provide that basic foundation of centralized care. Number three, which comes actually before what I mentioned in number two, is the enrollment of people into receiving the health insurance and having access to the services, which we saw with the Affordable Care Act. That was a significant barrier initially when it was implemented. Number three, then after having the access on that enrollment and the primary care workforce, is actually the access. How many providers do you have that can provide that service, and in what radius? Number five, the choice of providers or services included in that coverage plan can also limit and significantly affect quality of healthcare. Then also the access to subspecialty care, right? Not just the primary care and other referral services. And then finally is the measurement that Dr. Steinberg talked about. The measurement of the quality of those services needs to also be incentivized and needs to be used for continuous improvement and delivery of quality services. So it's complicated.
It is, and it's and you know, where would America be without complicated policy changes? And I think that's sort of part and parcel with where we're at. And I really, you know, as I'm hearing your presentation, and we heard from Dr. Fazio and Dr. Steinberg, there really is something to be said about this issue around data collection, having high quality data, looking at the data, and then also looking at really where we're at when it comes to the workforce, because I think a lot of these gaps that we're acknowledging are coming from are really workforce related, and do we have the personnel and the spaces in order to address the needs of the patients that we're trying to care for. And so my last question to you is, you talked about some of the amazing work that the ACA brought about. You talked about some of the challenges to the ACA. But one of the things that you didn't talk about were really, who were those populations that were left out? Who didn't benefit from the ACA, and for what reasons they were left out? And then how can we restructure the system to ensure that there's more equitable access to insurance and to care?
Well, one of the things that also, thank you for that question. One of the things that Dr. Steinberg also mentioned is the fact that we're still living in a fee-for-service oriented health insurance system, and the incentives are misaligned with our ultimate goals. So I think that's the overall, the answer is that we need to improve or either modify the Affordable Care Act to be able to continuously grow on having the right incentives, and also being more inclusive of the populations that were left out initially. And the answer to that is essentially have it be more like either universal health care coverage or more of a Medicare for all type of system, which would also include the increased access to technology, etc. Some of the populations that were, well, there's several ways to look at it. It's like who was left out or who is out right now. And if you look at a snapshot of who is uninsured right now in the United States, the majority of them are foreign-born Latinos, and some of these are, folks that that are sometimes called undocumented citizens. So the Affordable Care Act did not cover or provided services to them directly, rather than, they did include a large provision of funding for community health centers and federally qualified health centers, which does essentially service every single population regardless of their ability to pay. The other large majority of people that were left out is sadly from the states that opted not to expand Medicaid. And if a lot of people were either eligible for Medicaid and hadn't enrolled before for varied reasons, and either fear or lack of knowledge, etc. But others, once the Affordable Care Act was passed, were interested in enrolling, but if their state did not actually accept the Medicaid expansion and did not opt to participate, then they remained uninsured. And there's that probably amounts to 10 to 15%. And then there's another amount or a chunk of the population that either qualified for subsidies and was not interested because they perceived or encountered a cost that they perceived was too high to participate in the health insurance marketplace, or they just opted not to participate. And that was about another 10 to 30%, depending on the area. And that has been highly variable. Besides that, there are folks that just essentially have been left out with no other option rather than, the safety net care. And there are folks that have opted not to pursue health insurance coverage and actually get penalized for it.
Thank you. And I think it's really important to think about how the decisions made by leadership who were against the Affordable Care Act because of political beliefs and not necessarily based on the heart and matter of the issue really had a downstream impact on the individuals who ultimately needed that access to affordable insurance and some of the other benefits that came along with the expansion of the ACA. And I think there are political ramifications to policy decisions that are often not addressed. And thank you for bringing up the discussion around undocumented individuals here in our country. And as we are sort of still in the throes of this pandemic, we still see that some of those individuals in that population are sort of left out on the margins when it comes to receiving care. And also their ability or their interest in receiving vaccines as we try and address the pandemic and move towards herd immunity if we're ever going to make it there. So I want to say thank you, Dr. Portela Martinez, and I want to turn to Dr. Ross Jones for our last batch of questions. And really this part of the discussion is going to focus in on men's health. And Dr. Jones, my first question to you is, I just commented on the COVID pandemic. How has COVID-19 impacted health in men, and what are some of the potential long-term implications on the delays in access to care that you are seeing and that you anticipate to see in men going forward?
Sure. So what we see when we look at cases globally, men have been more affected by COVID, and that's going throughout the entire spectrum. So men are more likely to be diagnosed with COVID. When they do come in the hospital, they're coming in with more severe cases. They're more likely to be intubated, and ultimately they're more likely to die. And this is globally. When we look at the first cases in China, men were more than 80% of those cases. In Italy, it was around the same, around 80 to 90%. Here in the US, those differences are still continuing to show up. When we think about why that is, we can look at some of the comments from our other panelists. Men are more likely to be uninsured, unlikely to access healthcare. They also have higher health risky behaviors in terms of smoking, more likely to be physically inactive. And then they're also less likely to take those precautions that we know to prevent COVID. So wearing masks, making sure they're following social distancing. And then when they do get sick, they're less likely to get care because of perceived views around masculinity. Men don't get sick, men don't come to the hospital, men don't want to go, all these things that, traditionally we kind of view as in terms of masculinity. So long term, this shows that we're going to have more men who are sick, because we know from the long haul from COVID that COVID produces a lot of long-term symptoms, from cognitive impairment to the respiratory issues that we're all familiar with. It gives us a path forward, though, when we think about why are all these problems with men. Like Dr. Portela was mentioning, I think we need to think about how do we increase access to care. Is that through universal coverage or any other mechanisms to make sure? Also, when they do have these long-term sequelae, how are we going to deal with that? How do we make sure that our patients are able to get the care they need to deal with these challenges? And how do we make sure that they're healthier so when the next pandemic comes along, that they'll be able to be more resilient in those communities?
Well, I'll tell you what, Dr. Jones, men do get sick, because I was seeing them in my emergency department with COVID-19. So as much as we try and use that masculinity as a defense for some of the poor decisions we make, it certainly isn't the case. So my next question to you is, as we're talking about the issue around men's health, we often think about delays in diagnosis, less likely to have a primary care doctor, less likely to take medications. So we have questions around medication adherence and just overall compliance with screening. These are all issues that we typically hear about when it comes to the struggles that we are dealing with. We're trying to make sure that that the 49% of the population of men in this country actually stay healthy. Can you talk about what are some effective methods to activate men to engage in their own health and be and just overall engage with the healthcare system that we have?
Sure. So I think for us, what we found here at U of Health Jacksonville is that you really have to meet people where they are. So that means either physically and mentally. So when you think about COVID, for example, here in Jacksonville, the first testing sites required you to go to an area of town that did not have public transportation, and then you had to be in the car. So most of the men who are the most vulnerable didn't have access to either of those. So what we did was try to do a map of our patients where we knew that there are going to be vulnerable spots in terms of health disparities, in terms of hypertension, obesity, and we actually did pop-up, walk-up testing sites. So the men could come right up to our sites to get their testing. And then when we think about mentally, we also say who's telling them and providing the advice for our male patients. What we found is they don't really like to listen to us in the healthcare. They don't like to come from direct authority figures. So we've been employing a lot of community health workers. Community health workers are lay people that we've trained to provide education or other health promoting behaviors in our population. They really like listening to the community health workers. They're able to talk to them in a language I think that comes a little bit better. And there's kind of those power imbalances that prevent some people from dealing with the healthcare system are a little bit eroded. So for example, we have in our program where we're actually using community health workers to teach seniors how to use telemedicine. Our uptake for telehealth among seniors was around 10% since we started this program in about 3 months ago. We've seen that we have about 25% of our seniors are now able to access telemedicine. And that's because those community health workers are able to spend the time they need. As a busy clinician, we don't have more than those 15 minutes to really get everything we need done. We now have a person who can sit down with them, explain to them why it's important to use telemedicine, actually work hands on, sit shoulder to shoulder with them, walk them through that, and then tell them more about their health and why it's important to engage in the system and what things they can do outside of the clinic to really remain healthy.
Thank you. And my last question for you, Dr. Jones, is how can primary care physicians address the mental health challenges that men face along with their other health conditions? And we know that those mental health issues are often the reason why we don't go and seek care, or we don't have that conversation when we are seeking care. We don't answer honestly in those questions, and those mental health issues often go undiagnosed and undertreated.
Right. So mental health is a huge barrier, especially in all health, but really in men's health. I think it goes back to stigma. When we think about, again, going back to those traditional views of masculinity, men don't want to show weakness. It can be a source of shame. So what we really have to do is, one, we really have to educate about what are some of the common signs and symptoms of depression. So for example, in my patients, a lot of them will come in and saying, I'm just really tired. I just don't have any energy. And then when you try to get to the root of why that is, and they're like, are you feeling down? They're like, oh no, I just don't feel like myself. But they'll never want to be labeled as depressed, or they just feel like I'm worrying about a lot of different things, instead of saying that that's anxiety. And we try to make sure that we talk about that and we explain that a lot of people have depression, a lot of people have anxiety, and it doesn't take away from you as being a man or your ability to provide as a provider or caretaker, which a lot of people use as their primary identifier and definer of their self. So we really have to make sure that we're making sure that people are aware of the common signs and symptoms, make sure we're checking in, and then also give them resources. So not just say you're depressed, but this is the ways that we can help. These are some things that you can do. What we've also done is sometimes people are weary of getting a label from the healthcare profession. So we've actually reached out to the pastors to provide some mental health training. The men in our community a lot of times feel have a really good trusting relationship with those pastors and are willing to listen to them. So we gave them the training so they can recognize the signs and symptoms, and then also refer them to mental health providers that can provide culturally competent care to our male patients.
Wonderful. Thank you, Dr. Jones. So I want to turn now to try and get some more questions from the audience answered. So for the audience, please take advantage of the Q&A section of the webinar, and I will try and get through a handful of questions as we move forward. And I actually want to start with a question both for Dr. Steinburg and for Dr. Portello Martinez. And it's I think a question that you all both touched on in your presentations. And the question is, healthcare is not considered a right in our country. It's a commodity. How can we achieve health equity without making healthcare a right? I'll go to you first, Dr. Steinburg.
Okay. Well, I do think that's rather foundational. And we've been kind of working around the edges and not really addressing that issue in our nation. And but perhaps with the, as I said, the real concerted effort and focus on health equity, that discussion will be had. But as you know, that's a politically charged topic in our nation, and our nation is founded on individualism and not communalism, and so we have much to do in that area. But I am encouraged by the fact that health equity is really an important topic on the agenda. But yes, that is foundational.
I agree 100%. And thank you for the question. It also makes me think of this really cool article that Dr. Berwick published over 10 or 15 years ago called The Toxic Politics of Healthcare, which basically outlines the fact that most Americans think that everyone having access to healthcare is a good idea. And, you know, there's some type of consensus on that would be the right thing to do. But most of the difficulty and the lack of consensus comes around the policy, the actual policy of how to make that happen and how to pay for that to happen. So, and it talks about how, although we believe in principle it's a good idea, there is this ambivalence about how we take care of the poor or we take care of the vulnerable, of who would be responsible for essentially taking care of folks, and that idea of individualism, as Dr. Steinburg mentioned as well, of everyone having to kind of support themselves 100%, right, regardless of the fate or how healthy or how sick somebody is in their current state. So I think that 100% we have to just call it what it is. We need universal healthcare. We need healthcare should be a right, but we're probably not going to be there for a while. And like Dr. Steinberg said, then a bridge is this inclusiveness of health equity and what it means and addressing social determinants of health.
Thank you for that to the both of you. Dr. Fazio, I have a question for you. And we talked about the workforce related to primary care, and we tend to look at this through the lens of physicians and how we can expand that pool. But as Dr. Ross Jones mentioned, he talked about using community health workers. There's other individuals that are also involved in the process, whether it's the nurses that are there, the frontline staff. What do we need to do to make sure that those individuals are both available and then also approaching the individuals that are served by that primary care clinic from through the lens of health equity, so we can improve care for all patients?
Yeah, no, that's such an excellent question. I mean, I know we've sort of mentioned the importance of interprofessional education, which I do think is foundational in the way that we learn about medicine and teach our doctors, as well as our PAs and pharmacists and social workers. But our teams are so much bigger than just that, as you point out. And I think, you know, what in my experience working in a patient-centered medical home, I mean, one of the wonderful things is sort of building those teams. And it really does take the entire village, so to speak, to care for a patient population, and including the medical assistants, right? And including the community health workers, and including the social workers in your huddles, in your weekly conferences, in sort of helping them to co-own the health of the population, including those social determinants, I think is sort of fundamental for that working, so that everybody feels valued. I think we traditionally, medicine is so hierarchical, but that doesn't work. You can't take care of patients that way. Everybody is all hands on board. And I think the more you value every single person on that team, because they all uniquely contribute so much, the better you can actually provide for your patients.
Thank you for that. And Dr. Jones, you talked about using telehealth to access some of your patients, particularly your elderly patient populations in Florida. But one of the questions from the audience members is, how do we make sure that we're engaging rural health, specifically with using that technology? And yes, we're talking about seniors, but how do we think about those individuals who are coming from, rural communities with maybe limited access to broadband or high-speed internet, or to smartphones, or whatever other technological barriers they may have coming from a rural setting?
Right. So that's a great question. So one of the things that we did is we really mapped to say, what does it really take to access telehealth, right? So it's just not just, we always make the assumption that it's just that if they have a smartphone, they can do it, but it's about, do they have broadband in those communities? Do they have the know-how? So what we actually did was actually partner with community partners to make sure that we can actually advocate as a large healthcare system to have broadband expand out into those rural communities. So it's not just those who are within the urban core, but we have to make sure we have a lot of outlying rural communities in Jacksonville, how to make sure they have that access to healthcare as well. And then make sure that the people who are in those communities know how to use it too. So we partner with other community agencies within their local communities who can help them right on site as well.
Great, thank you for that. I want to go to, again, both well, I'll just start with Dr. Martinez for this one. Can you talk a little bit about the role of insurance providers in this space, as we talk about payment reform, as we talk about making sure that they are involved in advancing health equity? We were going to have a panelist who was unfortunately unavailable to try and tackle this question, but I would love to hear what your thoughts are on how we can engage the payer side as we look at promoting health equity in primary care.
Okay, I think I can actually piggyback off a couple of comments that have been shared in this presentation as well. A couple of things that come to my mind are, one of the things that Dr. Facio mentioned is that we need to be able to, for example, in light of COVID-19, the adoption of telehealth happened very, very quickly, where it hadn't happened before. And we have recognized that that's definitely a vehicle for providing access to populations that perhaps had other difficulties with transportation, et cetera, of getting into the clinic, recognizing at the same time that it does poses some disadvantages for some of our populations that may not have access to technology. But from the insurer side, ensuring that there's proper reimbursement or equal reimbursement, as she mentioned earlier, is very important to be able to continue access to care. Another thing that insurers have done, and is especially Medicaid and Medicare, was initially when the Affordable Care Act was passed, there were increased reimbursements for primary care services and primary care providers, which is significant. It was significant at that time, but that had since stopped. Another thing that insurances can do, which Dr. Steinburg alluded to, is kind of looking at, or continuing to look at, which has already started in the last decade, but it has, questionably been a little slow, is how can insurance help cover some of the costs of healthcare that are associated with social determinants of health? So we know that social determinants of health, and for example, not having transportation to go to your doctor's appointment, can be a barrier of receiving access to care, or even receiving your annual physical. Can that be, and some insurances have started doing that, can that be a potential covered expense? Another thing that has occurred is that since the Affordable Care Act, all preventive services that were considered part of essential primary care benefits had no copay, and that was a relatively new change. For example, I remember prior, maybe getting an IUD would have a copay of $100 or even more, and since the Affordable Care Act was passed, that was covered. Dr. Steinberg mentioned somewhat about this big kind of wave of interest in paying for health equity related measures, and some insurances have created these dashboards that have health equity measures in them. This CMMI, actually CMMI, not CMMI, CMS has this health disparities dashboard that's available online with a map of the US where you can track different diversities, different disparities by race and ethnicity and geographic area. And that can, part of the idea is that insurers use that information to track some of their own quality dashboards and some of their pay for performance incentives. So a little bit all over the place, but there's so much that insurers can do, and as well as continue to support pay for performance and quality-based programs, as long as they are also providing like the fundamental building blocks that primary care and that the specialty services need to be able to provide that quality care, right? So those are a couple of things that they can get started with and they continue to build on.
Wonderful, thank you. And to piggyback off of that question, I want to turn to you, Dr. Jones, because you talked about engaging pastors, you talked about community health workers. A lot of these efforts that we're doing that sort of fall outside the traditional scope of a primary care practice are not funded, or if they are funded, it's through grant funding or it's through a special project, and it may not be there, for the next, after 3 or 5 years. Can you talk about ways that we can formalize these structures and make them a part of the institution, make them so that these are continued components of primary care, as opposed to one-off projects that you may see one health center doing, or one academic medical center doing, or one hospital doing?
Sure. I think one of the things is that it goes back to payment. I think we need to think about some of those alternative payment methods that Dr. Steinburg mentioned. I think ACOs, or accountable care organizations, is a particular powerful vehicle for that. So when we can when we get this chunk of money that we can use to pay for these wraparound services and these other programs that really tackle the social determinants of health, we can then prove that these savings will be reduce the overall total cost of care for our patients, which will result in better care for the patients, increased quality of life for the providers, and then reduce costs to the payers, which I think ultimately that's what they're there for, is their bottom line. I think that's what we really need, how the payers really can affect these and make sure that these programs are sustainable. So
Great, thank you. And then I just want to go last to you, Dr. Fazio, because I think it's, as we talk about a lot of this conversation, we've really focused in on two sides of things. One is paying to make sure that primary care is sustainable, but then also to make sure that the workforce is there. And you made an interesting comment earlier about making sure that students are exposed to primary care outside of traditional academic medical centers, getting them into the community. Can you talk about some of the work that you're doing at your medical school in order to help students to get that exposure, which isn't something that may be done in other parts of the country?
Yeah, no, thanks for the question. I mean, it's a work in progress. I think one of the things that we've been doing here is trying to actually get students involved in primary care practices across the spectrum in their first year, which really introduces them to some of the fundamental elements and tries to kind of spark that joy. But I do think there's so much value to learning medicine in the communities. And we've just really, I think trying to get preceptors and faculty across the spectrum, of our university who would be interested in having a student or a series of students. And one of the things that I think we've always struggled with is how difficult it is being a primary care provider, particularly a full-time primary care provider and teaching. And so, we've structured things so that there's a compensation, or at least a forgiveness for RVUs, which I think goes a long way. We've also done some sharing so that a practice can own a student or a series of students and not just one provider. And, and I can say universally, the students, before they get involved in the experience, will often say, that's a long way to travel. And you give them 1 or 2 weeks there and they say things like, I don't think I've ever had an experience like this. And what's so valuable, outside of obviously the setting of primary care and seeing the patients and looking at the social determinants of health, is having that longitudinal relationship with a faculty member so that you can kind of observe their growth over time. So it serves educational purpose as well as sort of the fundamental teaching of primary care. But I think the more community involvement we have, the better, and probably the more valuable the experience is, because the community the provision of care is so very different from what happens in an academic medical center. Both important, but just seeing one side of it gives you a very limited view.
Thank you for that, Dr. Fazio. And I just want to say thank you to all of our panelists for joining us and our presenters. Thank you to Dr. Steinburg, Dr. Fazio, Dr. Portela Martinez, and Dr. Jones for joining us. This has been a really rich discussion, talking about a myriad of topics related to addressing the issue of primary care and advancing health equity. I want to say thank you to Dr. Reed for her continued vision and leadership of the DICP. Thank you to the DICP staff, Ying and Jasmine and Jackie, for helping to pull this together. There is some contact information of some of our presenters on the screen, just to give you a quick update on future events that we'll be doing through the DICP. We have we're continuing on with the Leadership and Faculty Development Program over the course of the next few days. We have 2 other conversations that are happening towards the end of the month. There is a short poll that we'd love for you all to participate in that will give us some feedback on this presentation and help us to think about future considerations for our discussions going forward. And again, thank you to the panelists. Thank you, the DICP team. And thank you to all in the audience for joining us over the past 2 hours or so. And we look forward to working with you and seeing you in future conference events that we host. Take care, everyone.